All right, so first off, we have to talk a little bit about how an EKG works. Okay, so an EKG is essentially a graph, right? So what are we plotting in that graph? We're plotting the motion of positive and negative charges over time, right? So the x-axis is time, the y-axis is millivolts, or electrical potential difference. Okay? The way that we do this is with an electrical meter, a voltmeter. Okay? And if you, maybe you remember from physics, maybe not, voltage is the difference in electrical potential, right? So voltage only makes sense across 2 points. You know, like a battery has a positive end and a negative end, and there's a voltage between those two, okay? Well, when we look at electricity moving through a system or moving through a structure, electricity has positive charge and negative charge. And electricity, like everything else in the universe, does move through space, okay? It moves through objects. So like if we take the simple analogy of a wire, right, a copper wire, all right? So if we hook up positive and negative charge, a voltage across that wire, electrons are going to go shooting down that wire, and yes, they're going to heat it up because there's no load, right? But nice and simple. Okay, so we have electricity flowing through our wire. We can measure the flow of charge using a voltmeter. Okay, so that's kind of what we're seeing here. Only instead of a wire, this is a conducting cell. Okay, so think of it almost like an axon of a neuron, right? So you have a long sort of tubular cellular structure. Okay, it has a membrane potential, which means it has positive charge on the outside, negative charge on the inside, or when depolarized, like in red, that flips, right? So in depolarization, we go up above the positive axis. That means we have positive charge on the inside. Remember, that's how we defined it. Okay, so here what we see in A is we see an action potential moving from here to here. And we have our meter set up so that we can measure that. So as the depolarization occurs, positive charges are moving in this direction, right? Why? Well, number one, they're attracted to the negatives that are inside. And number two, we get continuous depolarization of the membrane. So we have positive charge moving in this direction. We have our meter oriented, so the negative is down here and the positive is over here. So we have positive charge moving towards the positive electrode. So we get an upward deflection. See that? Positive moving towards positive gets you up in positive. All right. Now, what do we have here? Well, here, the depolarization has finished, okay? So electricity is no longer moving in that picture. You see there's no vector. So what we see in our tracing, in our EKG, now we're back to zero because there's no charge moving between our probes, between the two ends of our meter. Okay? Well, what about on the other end? Okay, so now the cell is going to repolarize. So depolarization completed. Now relaxation. So repolarization is going to occur in the same direction. So here what we have negative charges on the inside of the membrane, and they're moving towards the positive lead. Negative charge moving towards the positive lead, negative deflection. Right? Here, let me move my recorder. I need to just make a spot on my slides for that thing. All right, so you have negative charge moving towards the positive lead, so we get a negative deflection, right? You would also get a negative deflection if you moved positive charge towards the negative lead, right? Just to clarify. Now then here, repolarization has finished, okay? And lo and behold, we are back up to 0 because now there's no more electrical vector. There's no more flow happening. So, positive charge moving towards the positive is upward. Negative charge moving towards the positive is downward. All right? And we're starting to see the basics of an EKG because we see that a depolarization wave tends to be more on the upside, and a repolarization wave, well, in this case, tends to be more on the downside. We'll talk more about putting it into 3D here in a minute. So this is ultra simplified. This is basically just how does the EKG work, okay? We haven't really attached it to a heart yet, which is kind of the important bit. Okay, so when we attach it to a heart, what we see empirically is a pattern that looks like this. All right, so we have, where is my P wave? Why is there no P wave in there? Hold on a second. I just want to talk about the normal first, okay? So this, when we hook a patient up to an electrical meter, this is the pattern that we get, at least if we do it in a systematic way. All right, so we have no change, no electrical activity. Then we have an upward deflection, that's the P wave. The first upward deflection reflects atrial depolarization, right? So the atria depolarize. After they depolarize, they contract. Okay, so it means that after the P wave, the atria are contracting. Now, once that signal reaches the AV node, do you see how there's between the end of the P and the beginning of this structure, there's this sort of space? That's your AV nodal delay, right? That's your AV node, nothing happening. It's working its way through the AV node. Then from there, we get our QRS. This is ventricular depolarization. Now, one of the first things that you're going to see is, okay, atrial depolarization is kind of wide and bump shaped, right? The QRS is pointy and very short. Why? Because the conduction through the ventricles is really fast. We talked about that. The Purkinje fibers, the bundle branch, and the AV bundle, very rapid conduction. So we get a very narrow curve that's very sharp. Okay? Then we have this ventricular contraction is occurring here. All right? So this is depolarization, contraction. Then the T wave is ventricular repolarization. All right? Now, so you've got atrial dipole, ventricular dipole, ventricular repole. Now, if you're thinking, you'll notice there's something missing. What's missing? Atrial repolarization is hidden inside the QRS complex. We don't see it because there's so much more ventricular cells and mass than there is atrial cells and mass. We don't see atrial repolarization, and it's because it's happening at the same time as something much bigger, ventricular depolarization. So atrial repole is hidden inside the large QRS complex. All right, so PR interval, right, is approximately the same as the AV nodal delay, right? So that's explaining that bit. The T wave, down here, the T wave is longer than the QRS. And it's because depolarization happens faster than repolarization does. And depolarization is the result of that rapid conducting system. Repolarization isn't. Like, there isn't a repolarization signal. Heart cells repolarize on their own. So there's a wider distribution of time. We don't get everything happening at the same time. We get relaxation happens over a wider range, so we have a wider T wave. That's also why the voltage of the T wave is lower, is because the cells are not all repolarizing at exactly the same time like we see with ventricular depolarization. During the QT interval between the Q and the T wave, that's when systole is happening. Okay, that's when the heart is contracting. This is a place we look at when we are assessing a patient for myocardial infarction, because it's during this time of the EKG that the heart muscle itself is contracting. So if that heart muscle is sick, the place you're going to see abnormalities is between the S and the T. Okay, so one of our common a STEMI is an ST elevation MI. So it's a myocardial infarction that results in an elevation of the ST interval on the EKG. See? So you can use these things for diagnosis. Hey, come back here. Why are you doing that? Why are you doing that? All right, so that's the normal. Let's back up a little and see what nope, going forward still. All right, we did positive, negative. Okay. So the top graph, if we were to measure a contractile cell in the heart, the pattern is what we would see here at the top, right? So we have our depolarization, our plateau, right? And then repolarization, depolarization, plateau, repolarization. Because the plateau, remember, is where calcium is entering that's going to cause contraction. On the bottom, ventricular only, that's where my P wave went. Okay, ventricular only. This is what we would see in the conducting system. Okay, so we would see fast QRS, T, fast QRS. So the QRS is going to line up with the depolarization of the contractile cells. And then the repolarization, the downstroke, you can see that it lines up with the T wave. So now, the direction of these leads, like QRS, you look at that and there's plus and minus. So what's happening there? The heart is a three-dimensional structure. Okay, so at no point are all of the electrical charges ever going to be going in one direction, right? Because it's a three-dimensional structure. Which means in order to see what the heart is doing electrically, we have to look at it from multiple angles. Okay, those are our different leads in an EKG. They're different camera angles on the heart, looking at it electrically. So because of that 3D arrangement, our QRS usually has both an up and a down stroke component to it. And that has to do with the direction that electrical charges are moving through the heart.